certificate on the grounds of the short stature. In history, he was born of a non-consanguineous marriage and a normal full-term vaginal delivery. He had an uneventful birth history with a normal genitalia, and the testicles was noticed by mother in the scrotum. His birth weight and birth length were not available but were reported to be average, and according to his parents, the developmental milestones were achieved at the normal age. At the age of 2 to 3 years, his parents observed the appearance of a facial hair and penile tumescence, which was associated with that of increased height gain. They could not recall any significant behavioral change or semen discharge or nocturnal emissions, and he was shown to a local practitioner and advised some investigations, but there was no specific treatment which was given. So the parents clearly remember that he has stopped gaining height at an early age compared to the peers, and he was shortest in the class by around 6 standard, that's around 12 years of age. And he was having an average academic performance. There was no history suggestive of any chronic systemic disease, hypothyroidism, or pituitary mass defect to explain his growth failure. There was no history of any headache, seizures, or visual disturbance, which suggestive of a hypothalamic tumors, that is including hematoma, dysgerminoma, or optic glioma. There's no history of any head trauma, previous radiation exposure, or any CNS infection, including encephalitis or meningitis. There is no history of any bone deformity suggestive of McCune-Albright syndrome, mucocutaneous hyperpigmentation, and hypercortisolic symptoms suggestive of congenital adrenal hyperplasia, abdominal pain or fullness which is suggesting of a tumor in the abdomen, or an scrotal mass suggestive of a testicular tumor. There was no history of any exogenous anabolic steroid use. And in the family, there was no history of any childhood precocity or any salt wasting crisis, infertility, or exogenous androgen use. So in his family, he's the eldest of his sibling, and two of the younger siblings were much taller than him. And his younger brother, which was 14-year-old, who's already 168 centimeter. And his father complains that he's much shorter than his own father, but significance was not assessed because the midparental height was not available. And as well, there was also the mid-population norms. This height of a man, which was 164 centimeter, was also normal. On examination, he was having a muscular build, adequately virilized. There is no facial dysmorphism and skeletal deformity. There is no capillomacule, mucocutaneous pigmentation, nevi neurofibroma, adenoma sebaceum, chagrin patches of goiter. There was no signs of any hypocalcemia. The blood pressure was normal with no postural drop, and the visual acuity was normal in both eyes. On anthropometry, his height was 137 centimeter, which was minus 5.3 standard deviation score, suggesting of a severe short stature, where the height is less than minus 3 SDS, and the midparental height was 169.5 centimeter. Since the patient's height SDS is more than 1.5 SDS less than the MPH SDS, he is short for his genetic potential. And his upper segment to lower segment ratio was around 0.9, which was suggestive of a proportionate short stature. And he was having a weight of 40 kg with a BMI of 21.4 kilogram per meter square. On genital examination, there was no genital ambiguity, and the testicular volume was 12 ml bilateral with a normal consistency and no mass palpable. But this was slightly discordant with the rest of the genital examination, where his stretch penile length was 10 centimeter and pubic hair stage was recorded 5th stage, where we expect a testicular volume of around 20 to 25 ml, and his systemic examination was unremarkable. So to summarize, from the history and the clinical examination, this is a case of a severe short stature with an untreated precocious puberty presenting at 22 years of age. So precocious puberty is defined as the onset of the secondary sexual characters before the age of 9 years in males. And in our case, this patient has presented at the age of 2 to 3 years of his age. So this precocious puberty can be of two types. One is gonadotropin dependent, another is gonadotropin independent. So as the name suggests, the gonadotropin dependent depend upon the reactivation of the hypothalamo-pituitary gonadal axis, which occurs at an early age. That is why it has become pathological or central precocious puberty. When it becomes gonadotropin independent, it's called peripheral precocious puberty. But at this point of time, a patient presenting at 22 years of age with no clinical markers favoring or excluding the diagnosis of peripheral central precocity, we cannot commit to a single broader category of diagnosis. So we would like to go for further investigations. So from reviewing his older records, the serum testosterone at the age of 2 to 3 years was already in the adult range, which was around 9.5 nanogram per ml. And the age of his 21 years, there was already, which was again shown that the serum testosterone was elevated with a suppressed FSH. And the investigations from our center had shown that the baseline workup, which is including a complete blood count, renal and liver function tests were normal. And on hormonal evaluation, he had an elevated serum testosterone with a suppressed gonadotropin, that is FSH and LH were suppressed. This biochemical picture is more or less suggestive of that of a peripheral precocity. And adrenal source of the androgen was also worked up, and the beta HCG was normal, and serum cortisol 17 hydroxyprogesterone ACTH, and is having a thyroid function test, which was also normal. So assessing the function of this testis in the terms of spermatogenesis, a semen analysis which was done was showing that there is a hypospermia as well as oligospermia, where the volume was less than 1.5 ml and the sperm concentration was less than 15 million per ml, according to the WHO established criteria in 2020. But still, the sperm quality was good in terms of motility as well as morphology, where there are more than 4% of the normal forms. That means that this patient, despite a complete suppressed gonadotropins, he had maintained a good amount of spermatogenesis. That means it's not only the old school thought of FSH playing an important role in spermatogenesis, the intratesticular testosterone also play a very important role in the sustenance and the maintenance of the spermatogenesis. In the radiological evaluation, he had a bone age of more than 16 years and a skeletal survey was normal to rule out a polyostotic or monostotic fibrous dysplasia, and there was no evidence of any testicular mass in the ultrasound scrotum. And the CCT abdomen, it was done from outside, which was normal, and it was including bilateral adrenal. There was only no tumor or any adrenal hyperplasia. So now we have a patient who had a background history of a peripheral precocity. And since his father is also complaining that he's shorter compared to his father, we did a biochemical workup of him and it was normal. And at this juncture, how do we approach to a case of a precocious puberty in this patient? So first we have to establish a clinical diagnosis of precocity. So precocity is defined as the presence of the development of the secondary sexual characters before the age of 9 years in males. In our patient, it has appeared by around 2 to 3 years of age. So it fits the criteria of the precocity. After establishing the diagnosis clinically about the precocity, now we have to know from where the androgen is coming from. Either is it from the testicles or either it is from the adrenal. So we assess the testicular volume. So if there is a concomitant increase in the testicular volume with that of precocity, most likely the source of androgens can be from the testes. But this patient has presented at the age of 22 years. So we are not sure that he would already have a normal onset of puberty also. So testicular size cannot be reliable for differentiating the source of androgen. So we had a workup for the adrenal pathologies as well as an elevated as well as a testosterone also. So when the serum testosterone was elevated, the next step we proceed to that of the evaluation of gonadotropins. So if the gonadotropins like basal LH is in the range of a pubertal or elevated with that of elevated testosterone, that means there is a central activation of the hypothalamo-pituitary gonadal axis, suggestive of a true precocious puberty. But when there is a basal LH which is suppressed with that of an elevated testosterone, that means the testis is having an autonomous production of the testosterone. There are three possibilities for that of the autonomous production of testosterone. One is HCG secreting tumor, and second is McCune-Albright syndrome and testotoxicosis. So how this autonomous production of testosterone happens in these three conditions is that, as I've already told, there is complete absence of gonadotropins. So LH receptors will get stimulated by either a molecule which share the structural similarity with that of an LH, like HCG, in the case of HCG secreting tumor. And second is about the LH receptor, which is constitutively activated, like in the case of testotoxicosis, which doesn't need a ligand. And the third is the McCune-Albright syndrome, which is a post-receptor signaling activation that can also lead to the increased synthesis and secretion of testosterone. So in our patient, HCG secreting tumor is a very unlikely cause because it is not likely that it runs a dormant course till the age of 22 years. And second, McCune-Albright syndrome is also not possible because it doesn't fit in the clinical criteria, which is requires 2 by 3 out of the criteria. That is McCune cephalomacule as well as that of bony deformity. And after the clinical as well as biochemical workup, we have kept the possibility of testotoxicosis as the diagnosis in this patient. And we went for the genetic evaluation. And for the further discussion of the genetic workup as well as diagnosis and discussion, I would like to invite Dr. Alpesa for the
Good afternoon. Thank you, Uttara. Based on the clinical history and physical examination, we have an adult who has presented with short stature, which is a sequel of untreated sexual precocity. Biochemical workup suggests elevated testosterone levels in face of suppressed or prepubertal gonadotropins. Radiology, we don't find a adrenal or testicular mass which can explain these findings. And very interestingly, in face of suppressed gonadotropins, uh, spermatogenesis is still maintained. So we are seeing that though the person is having oligozoospermia, the sperm quality is still maintained. So this might indicate that there is a pathology which is causing an increase in intratesticular testosterone, which is also leading to increase in circulating testosterone levels. And this could well be possible when you have an activating mutation at the level of LH receptor in Leydig cells. So we went ahead with the genetic testing after genetic counseling, and the clinical history that was provided was that this patient presented with clinical indications of short stature and precocious puberty, and he is suspected to harbor activating mutations in LHCGR gene, which encodes human luteinizing hormone receptor, which is present on Leydig cells. So the genetic testing was done from MedGenome Laboratory in Bangalore, and on genetic testing we found that there was a heterozygous variation in exon 11 at position 1733, which caused nucleotide substitution from adenine to cytosine, and this resulted in in protein. It resulted in a substitution of aspartic amino acid at 578 position to alanine. And this variation was further confirmed by Sanger sequencing, which detected the same variation in a heterozygous state. So this is the sequence chromatogram, and this chromatogram shows that this patient had a heterozygous variation at the position 1733, which caused substitution of adenine to cytosine, and this results in a double peak here. So there is a heterozygous variation in one of the alleles, and this is being represented in this sequence chromatogram. When we did a literature review on same amino acid substitution, we found that the codon 578 amino acid substitution has been reported in male limited precocious puberty or testotoxicosis previously in literature, and this has been reported in various studies. And not only this has been reported, the functional significance of this mutation has also been reported in vitro studies, and it has been found that when the mutant receptor is transfected onto the HEK cells, they are found to present with increased CAMP levels in absence of a ligand. That means constituting activation of LH receptor in absence of ligand. So how did we come to know that this variation was likely pathogenic in this case? We didn't have any very strong evidence of pathogenicity as per the American College of Medical Genetics classification criteria. However, in this patient, we had three moderately strong evidence of pathogenicity and two supporting evidence of pathogenicity. So moderate evidence of pathogenicity was that the mutation that we found was located in a mutational hotspot that has been described for testotoxicosis. I shall discuss this in more details. This variation was found to be absent from controls on 1,000 genomes database, and novel missense change at an amino acid residue where a different missense change determined to be pathogenic has already been determined. For example, in our patient, aspartic acid to glycine substitution has already been determined to be pathogenic, and we found aspartic acid to alanine substitution at the same position. So these are three moderate evidence of pathogenicity, and supporting evidence of pathogenicity were that multiple lines of computational evidence support a deleterious effect on gene, and this was through software such as mutation taster and polyphene, and the patient's phenotype was highly specific for disease with a single genetic etiology, that is male limited precocious puberty. So if we combine all these criteria, this variation fits into a likely pathogenic variation, because either we can take point number 4 where three moderate evidences are being fulfilled, or we have two moderate and two supporting evidence of pathogenicity. So moving on to familial segregation, we next went ahead with Sanger sequencing of father after genetic counseling. It was found to be normal. Our mother refused any genetic testing, although we inquired her and there were no clinical history of short stature or precocity in male members in mother's side. So the final diagnosis that we uh, made was male limited precocious puberty or testotoxicosis, which could either be familial or sporadic. Short of genetic finding, genetic testing in our mother, we can't be sure that this is familial or sporadic. This patient presented to us in adulthood with severe short stature, persistent autonomous testicular function, and with oligozoospermia. Moving on to literature review of this condition. So male limited precocious puberty or testotoxicosis is a condition which is caused by germline activating mutation in the gene for LHCGR, which encodes LHCGR or a G protein coupled receptor, which is present on Leydig cells in testes and also theca cells and granulosa cells in ovaries. Now, this receptor serves as a receptor for two closely related glycoproteins, that is LH and SCG, and it is in Leydig cells of testes. It is responsible through CAMP to increase steroidogenesis and testosterone production. Both sporadic and familial cases for testotoxicosis have been reported, and this condition, very interestingly, has sex-limited autosomal dominant inheritance. That is, it is expressed only in males, and the condition is totally silent in females. Most children present at age of 2 to 4 years, as was also seen in our case, and they present with gonadotropin independent sexual precocity with bilateral testicular enlargement, but the testicular enlargement is not proportionate to the degree of sexual development that is seen in these children. You have prepubertal gonadotropins, pubertal levels of testosterone, and there is evidence of premature Leydig cell and seminiferous tubular maturation because Leydig cells secrete testosterone, and this testosterone acts on Sertoli cells, on the androgen receptors, and promotes spermatogen. There is no evidence of central nervous system, adrenal, or testicular pathology on investigation, as was also evident in this case. And treatment is a combination of anti-androgen and aromatase inhibitor in order to arrest the development of secondary sexual characteristics and to improve final height. However, even despite treatment, median adult height in this last series of 25 patients, of which 21 were treated, was found to be 1.5 standard deviation below the mean for adult height in patients with testotoxicosis. Moving on to the genetics of male limited precocious puberty or testotoxicosis. So this is the structure of human luteinizing hormone SCG receptor. And as we can see, as a typical G protein coupled receptor, there is an extracellular domain, the 7 transmembrane helix, and an intracellular domain. The open squares actually represent inactivating mutations which cause Leydig cell hypoplasia or which presents as a DSD condition. And the closed circles and the dark circles, they represent activating mutations. So one thing is very clear, that while inactivating mutations are distributed throughout the receptor, as we can see here, the activating mutations are mainly focused onto the transmembrane helix. And even in the transmembrane helix, they are mainly focused in the sixth transmembrane helix, or the third loop of this transmembrane protein. So this receptor is coded by 11 exons, of which first 10 exons encode the extracellular part, while the 11th exon encode the transmembrane and the intracellular part. So all activating mutations that have been identified are single base substitutions, and the region between 542 to 581 amino acid of exon 11 is hotspot for precocious puberty point mutations, and this is the hotspot for male limited precocious puberty point mutations, and of which 578 was the position at which we found mutation in our case. Most commonly affected amino acid is 578 aspartate, as was also seen in our case, and most commonly reported mutation is substitution of aspartic acid to glycine, which is again a neutral amino acid, just like alanine, which was seen in our case. Male limited precocious puberty, it is thought that it would have 100% penetrance in males, and it was initially thought that this is true. However, there have been a single kindred has been reported where even a male who has germline mutation was not found to have the clinical expression of disease. So even this condition does not have 100% male penetrance. In the present case, management was mainly focused on counseling, on fertility prospects, because it has been seen that they may have decay in their reproductive capability. So the patient was offered sperm cryopreservation. There is a potential for transmission of this mutation to next generation, and if the in the male offspring, there could be expression of the disease. And we have done a baseline ultrasound scrotum, and we plan to periodically screen this patient with ultrasound of scrotum, because there have been reported cases of Leydig cell adenoma and germ cell tumors, which have been reported on long-term follow-up in these cases. The natural history of hypothalamic pituitary thyroid excess in male limited precocious puberty, it is variable actually. Initially, it was reported through 3 generations of patients with male limited precocious puberty. It was reported that an index patient who presented as child, they presented with gonadotropin independent Leydig cell function. A phase 2, which is represented by the father of the index patient, they found that you could have normal gonadotropin secretory dynamics and normal gonadotropin levels and reproductive maturity. And ultimately, this leads to an increase in gonadotropin secondary to diminished Leydig cell function and damage to germinal tissue. That means that you have an autonomous testicular function during the childhood phase, which leads to a normal gonadotropin function and then leads to hypergonadotropic hypogonadism. However, autonomous testicular function with suppressed gonadotropins, as was seen in our case, has been described in the literature. And I'll just finish by listing 3 other cases where autonomous testicular function persisting into adulthood with testotoxicosis has been described, and compare this with our case. So our case had a aspartic acid 578 to alanine substitution. In the case 3, the genetic testing was not done. A similar amino acid substitution at the same position was reported in case 2, and in case 1, the substitution was at amino acid 457. Both cases 1 and 2 received childhood treatment, and cases 3 and 4, they didn't receive any childhood treatment. And as we can see, there is sharp difference in adult height between cases 1 and 2 and cases 3 and 4, and this just emphasizes that it's important to treat precocious puberty in early stages, otherwise you end up having short stature. Testicular volume in all these cases was reported to be lower than that is expected for an adult. That for an adult we expect testicular volume between 15 and 30 ml. So this is because there is chronic suppression of follicle stimulating hormone. However, it is maintained in face of intratesticular testosterone levels. So you had suppressed gonadotropins in all these patients and high or high normal testosterone levels in all these patients. Sperm concentration, as I have discussed, they were all in the levels of oligozoospermia. However, none of these patients had azoospermia. In terms of fertility, in first case, the patient had fertility, had a daughter who didn't have any mutation. In case 2, the patient had fertility and had a son who was again affected with the same condition. Similarly, in case 3, and in our patient, the patient is unmarried. So the learning points from our presentation are that patients with untreated or inadequately treated sexual precocity can present in adulthood with short stature. And it is also important to understand that sexual precocity should be treated in order to optimize height outcome. In male limited precocious puberty, high levels of intratesticular testosterone, they promote spermatogenesis even in face of suppressed FSH. And fertility, risk of transmission to next generation, and testicular tumor development, they have been seen in long-term follow-ups. These are important issues which need to be considered in these patients. Thank you. So, sir, what happens is that if you have supraphysiological levels of testosterone, they get converted to estradiol and by themselves. So, in males, the negative feedback to hypothalamus and pituitary that goes by both testosterone and estradiol. So, yes, even supraphysiological levels of testosterone, they can suppress both LH and FSH. And then another example of this is patients with untreated congenital adrenal hyperplasia, who have supraphysiological adrenal androgens, and they have suppressed levels of LH and FSH, and they present with infertility. Despite having good levels of circulating testosterone, having good libido, having good erections, but they end up having azoospermia.
And suppose if this patient had come a little earlier, maybe before puberty, so what would you have offered him treatment wise?
So there are large series of patients with male limited precocious puberty, and those patients who present early, they can be offered a treatment of anti-androgen. For example, in earlier days, spironolactone was used. Now, agents like non-steroidal agents like bicalutamide are offered. And because you are blocking androgen receptor, this will lead to increased estrogen production. and this could in turn lead to advancement of bone age. So you need to also block androgen to estrogen conversion using aromatase inhibitor. So most commonly you use a combination of androgen blockade plus an aromatase inhibitor. So this could be spironolactone plus testosterone, or this could be bicalutamide plus anastrozole.
Right before this one. So, how frequent is testicular tumor development?
Sir, actually, this is a rare disease, not studied prospectively. Only few case reports are available. So both types of tumors have been reported. We know in testes there are two major compartments. One is seminiferous tubules where you have germ cells and Sertoli cells, and other is Leydig cells. So Leydig cell adenoma are expected that because you have a substrate, that is Leydig cell hyperplasia, because there is increased CAMP. So Leydig cell adenoma is expected, but people also found that these patients have seminomas and mixed germ cell tumor, and which has been proposed that because these patients have supraphysiological levels of local testosterone at inappropriate times, which are starting very early in life. So that may predispose them to development of germ cell.
Thank you.
Thank you. As usual, an interesting presentation from endocrinology. I just wanted to know how the motility of the sperms is normal in spite of low FSH, LH, like whatever sperms which are there.
Sir,
their motility.
spermatogenesis is a complex process, and it the Sertoli cells, which are important for nurturing and maintaining spermatogenesis, they express both receptors for androgens, which act locally from Leydig cells via paracrine action, and they also express receptors for FSH. And under the combined action of FSH and androgens, local intratesticular androgens, they stimulate spermatogenesis. So in this case, it is possible that because the local testosterone levels, the intratesticular testosterone levels that were maintained, that helped in maintenance of spermatogenesis. And there are certain mouse models which have also shown that if you have combined knockout of both androgen receptor and FSH receptor, that actually leads to absolute infertility or azoospermia. If you have only knockout of FSH receptor, to some extent fertility remains maintained, or spermatogenesis remains maintained.
Just a simple question out of my inquisitiveness. Like usually in adolescence or puberty, there is a growth spurt. So why these patients they don't have a growth spurt even if the puberty is precocious?
Why do they have growth spurt?
Why don't they have like they end up with a short stature?
Okay. So this is because they have a premature growth spurt. So this child, for example, at 2 to 3 years of age, he had accelerated development of secondary sexual characteristics associated with growth spurt, increase in growth velocity, and at that point in time, they have increased sex steroid levels with increased skeletal advancement as well, and this leads to premature fusion of epiphysis and ultimate short stage.
Thank you.
Yeah, on the fibrous
Yes,
displays there.
so we did a bone survey, skeletal survey, and we did a thorough physical examination for any cafe oleomacules. Both of these were absent. I mean, bone survey was normal, and skin examination didn't reveal any cafe oleomacule. Thank you, sir.